I think, yeah, the recording is started.
Okay, perfect.
Very perfect. Okay, this is one of the sessions of EndoLeaders show, and we are very honored and delighted to have the chance of having Dr. Andrea Galantino from Italy here. As you know, he's going to talk about the root canal retreatment, deep cleaning challenges, a very special topic, and we will learn a lot from him. Thanks for accepting our invitation, dear Andrea. And the stage is yours. As you know, we have Dr. Ahmad and Dr. Parisa here to discuss about the details that you are going to talk about. And
Perfect.
the stage is yours, dear Andrea. Please start your presentation formally.
Thank you. I thank you for the invitation to this discussion, and it's a pleasure for me to talk with you about one of my war horses, because I am very proud of our mission, that is to save teeth. So the game changer in this case is our skill to repair some mistakes made by previously made by some clinicians, and I will share to you some techniques and instruments to make this our mission more simple. So the first question I I tell to you is when do you when are we called to perform an endodontic retreatment? There are 4 cases. So the presence of periapical lesion of endodontic origin, the presence of persistent
Dr.
pain.
Andrea, we don't have your screen. Sorry if you haven't noticed that.
Dear
Please
Dr.
start.
Ali, we have his screen.
Do
You have?
you
Yes,
see my presentation?
Yeah, I can see
yes,
it.
we see it.
So it's my
Okay.
problem. Let me check why. Okay, go on. If the screen is
Okay.
good, yeah, go
So
on.
these are the reason when we perform an endodontic treatment. So the presence of periapical lesion of endodontic origin, the presence of persistent pain of a tooth, and there is a radiographically corrected endodontic therapy, or if there are recent incongruous therapies with false pathways or perforations, or if there is an incorrectly performed treatment, also without the association of lesion or pain, in which a prosthetic restoration of the crown must be performed, because when we have to restore a teeth with a prosthetic crown, we are responsible also of the endodontic health of that teeth. Also, if it has a root canal treatment of a lot of years. There is an interesting study of Orstavik. This score is the PI, periapical index score, that is shows us a criteria described by Orstavik in 1986. It's scored from 1 to 5 according to the absence or presence of radiographic signs of apical periodontitis, from the initial widening of periodontal ligament in the score 2 to the radiolucency of the bone, the score 5. This criteria can guide us to indicate to the patient the need to perform an endodontic retreatment. So this is a radiographic score. With the radiographic examination, we can draw also other consideration about root canal therapy. For example, we can see procedural defects in shaping, the incorrect cavity access, the apical transport, the perforation, some perforations, some stripping, some fractured instruments, some unidentified canals, or some blockages in canals. We can also see in a radiographic also root canal filling defects, like non-responsive cone continuity, the presence of void or bubbles in the obturation, the incongruous filling limits. For example, if the root canal therapy is short, at least 2 millimeters less from the apex, or the overextension to the radiographic apex. This is the alias classification. In accordance with what we have just said, we can draw some success criteria, clinical criteria, and radiographic criteria. It's important the presence of both of us, so also clinical and radiographic criteria to state that root canal therapy is correct. So, for example, in the clinical case on the left, we don't have suffering bone, so we don't have a radiographic criteria of pain, but we have clinic criteria of pain. The patients feels pain to that tooth. In the right case, we have radiographic present of suffering bone, but there is not clinical sufferance. In both of cases, we have to perform a root canal retreatment to correct the clinical aspect and the radiographical aspect. So in the right cases, we can also see the radiographic healing at 9 months of follow-up. So the next question is about prognosis. So which prognosis has our retreatment, our root canal retreatment? Because we have to suggest it to patients, and we have also to inform the patients of the percentage of healing we have in root canal retreatment. So in this famous study, about 4,086 teeth was examined about after root canal retreatment, and the percent of success in the retreatment is 77%. So it's about 80%. So it's a functional treatment. Retreatment, we can suggest a retreatment because we have a 9% of success. We can also compare. We can show to the patients the initial bone suffering, so the initial bone loss, and we can show also the healing at the follow-up to the patient. So we can show to him our goal, our final results, and he's very happy because we have done our mission, that is to save teeth. This is another case in which we have to perform another prosthetic bridge. So we have to retreat the teeth that will be the teeth under the prosthetic bridge. So this is also an interesting anatomy when we do the retreatment. And at 1 year of follow-up, we can appreciate the healing of the bone. So we can also compare some 3D views of the CBCT before and after a follow-up. We can show the healing of the bone also by a 3D view, thanks to CBCT. Or for example, in these cases of premolars, maxillary premolars, this is my final radiographics of retreatment. And this is a comparison of CBCT views initial and at a follow-up of 10 months among 1 year of follow-up. So we can show, we can see a good healing of the bone, and another time we have saved the teeth of the patient. And we also can be aware of the stability of the healing over time. The stability of the results obtained is absolutely dependent on the stable and long-lasting coronal seal. In this famous scientific study, the authors shows us the importance of the good restorative later than the endodontics treatment. So it's an important fundamental point of interest, also the restoration and long-lasting time coronal seal. So this is a case in which the good resto it has been made on bed endodontics. This is the tooth of my mother, and this is an endodontic treatment performed 47 years ago. So it's not a correct endodontic treatment because the apex is not shaped, the obturation is short, but there is no bone suffering because of a good coronal seal made by amalgam 47 years ago. So the importance of the coronal seal. And these are some cases of mine performed in recent years, but colleagues that performed the restoration was not able to seal correct my results. So, for example, in the case on the right, we can see the sufferance of bone because of the lack of coronal seal made by the colleague that made the restoration after my endodontic therapy. So the coronal seal, we know that after 21 days, the temporary filling material is not able to prevent a micro leakage. So if is it possible, we have to do the restoration, the final restoration immediately after our root canal retreatment. Okay. Maybe I will perform my final restoration max about a week, 1 week after the retreatment. In some cases, I make the direct restoration during the root canal therapy. So I made the root canal therapy and immediately the definite restoration. And I can use different types of matrix, like in this case. So I perform the root canal therapy and the direct restoration immediately. So I will prevent the micro leakage of obturation of canals by made the final restoration immediately. Like in this case, I work. I perform the root canal therapy with the automatrix during the therapy. Okay, I use matrix during the root canal therapy. Sorry, I'm listening other voices. No.
It's okay. I mute them. No problem.
Okay, perfect. So the importance of the relocation of deep margin, okay, when we do endodontics is fundamental to prevent the micro leakage and to have the long success time treatments. The cervical margin relocation, I made it during the root canal treatment. Okay, and I restore immediately the tooth. Okay. So these are cases of immediately coronal relocation and restoration. We can also use a fiber post. We can also insert a fiber post immediately after we do the root canal therapy. Of course, we use rubber dam in all our passages, quindi a perfect isolation of the tooth. And we put also a fiber post in the palatal canal. to the deep margin relocation, cervical margin relocation. And we can also put immediately also prosthetic crown if we have the possibility to print crown. We can also put it on the tooth in the same session. And this is an example of stability in time. So a good coronal seal will allows us to has long time stability of the result. Okay. Just a second. However, in some cases, even all the procedures are performed correctly from an endodontic and conservative point of view, we encounter failure. Why? There are some answers in this beautiful review. This is a case. It was I made the restorative and the endodontics, the endodontic retreatment. This is the initial radiograph, and after 2 months, the patient feels pain and also has an abscess. Even if I made the endodontic treatment with all criteria of shaping, obturation, disinfection. So why do we? Why I had the failure in this case? In this beautiful review, we can find some answers. For example, one of the cases. The first case of failure can be the presence of biofilm in not accessible parts of the canals, so where we cannot vehicle our irrigants. For example, apical delta, not good disinfected, or the fungal contamination of extra apex area. If there are some bacteria like actinomycetes, if there is cyst lumen and cholesterol crystals, these are all cases that failure cases. We cannot obtain the healing of the bone. Or, for example, is there are the contaminated filling materials by talc of the gloves, for example. So I always use gloves without talc because it can contaminate the filling material. I use paper cone of good quality because some fibers of paper cone can be vehiculated over apex and it can do a foreign body reaction. In the presence of alteration of the original morphology of the root canal, there is the 40% reduction of the success rate, and this is very important to show to the patients when we talk with him. Also, another case of failure can be an overextension of material. This is a thermophil. I used a lot of time. I used carrier-based technique. This is the overextension of Teflon, and after some 3 months, the patient feel pain, and we can see the overextension and the suffering of bone. So we can choose another kind of obturation method. So we put out the Teflon carrier from the canal, and we choose another kind of obturation method with the bioceramic sealer. I obturated by bioceramic sealer. and then the pain will disappear, and the healing, we can see the healing of the bone. So I asked you, when is the tooth preservable? It's a question I answer also to me. And like in the short sentence, the only is not possible is not to choose. So we can choose if a tooth is preservable. For example, I can choose when I made a CBCT. I use a lot of 3D radiographics or in retreatments, especially. So we can do also a diagnosis in a tooth that was asymptomatic for 40 years. I made a CBCT, and I see some fractures. So for me, it's not possible to preserve this tooth. So I can show to the patients these axial views, and I can explain to him that the tooth is not preservable. So I cannot perform a retreatment here. Or for example, when I see a J-shape aspect on CBCT, I suppose a fracture. So when I put the tooth under a microscope, I can see the fracture on distal root. So I suggested already to the patient that it will be fractured the tooth, and I have the confirm under microscope observation. Or, for example, this is another tooth. I suppose the old missed canal. In fact, this premolar had 3 canals, 2 vestibular canals and 1 buccal canal. So there is a missed mesiobuccal canal, and I have to retreat all the endodontic space, including the mesiobuccal canal. Or in this other case, the CBCT allows me to observe a deep split in this premolar. So there is a bifurcation of canal in the apical part. Okay, and I treat also the other canal, the other missed canal. This is a mandibular premolar, the same situation. There is a missed canal, and by CBCT I also can choose a surgery instead of having a retreatment, like in this case, in which the lesion is on the vestibular canal of the first premolar, and I also made, and I only made surgery on that canal. And this is the healing. CBCT is also useful to compare the results and to observe. For example, in this case, there are multiple lesions under the canals. We can observe in 2 dimensions and also in 3 dimensions, the 2 years follow-up, the healing of the bone. And we can show it to the patient, and he is very happy of this result because he preserved his teeth. So now, how can we increase the chances of success in retreatment? Let me show some trick and tricks. So we have some fundamental principles that have to be respected. These ones: the accessibility to the apical third, the overcoming intracanal obstacles, the management and obturation of reworked apices, and the disinfection protocol. So the accessibility of the apical third starts from the coronal point of view. So we have to remove a prosthetic crown or composite restoration, direct or indirect. The main difficulties to open a crown, maybe also a zirconia crown that is very hard to cut, and we also have the risk of microfractures, and we have to reduce the opening to the minimum necessary and use abundant irrigation on especially on zirconia. So, for example, this is a case. In this case, a colleague in 2016 redid the prosthetic crown without retreating the tooth. And in 218, the patient developed clinical and radiographical pain and a lesion. Since the patient has recently paid for the prosthetic crown, we decided to retreat the tooth by performing a minimal opening and removing also a fiber post in the distal root. So a minimally invasive opening on the zirconia. And we perform the retreatment. The next obstacles in canals are intracanal obstacles like cemented cast metal post, screwed metal pins like dentatus, or fiberglass post. The removal of melted metal pins is made by ultrasonic source, abundant irrigation, and we have not to try to force the pin to be removed when it starts to move, because we can allow fractures in dentin. I use especially this StarTix number 4. Or an ultrasonic source like a periodontal one. So we can vibrate with abundant irrigation the pin. Just to remove it. Okay. The pin starts to move, and we can put it out from the canal. The screwed pins like dentatus, I use this StarTix number 3 on an ultrasonic source, abundant irrigation. And with this ultrasonic source, we remove the cement composite in a counterclockwise direction. Okay. So we put out the screw from the canal. It's very simple to make. The most difficult post to be removed is the fiber post. We can remove it only if we have a magnifying system with illumination, a microscope, or loops with light. We can remove it with an ultrasonic sources. There is a consumption of the fiber post, or we can use also these. I like a lot of these long shank cutters. These are the Comet Endotracer, and they are of 34 millimeters or 31 millimeters. We have also a lot of diameters, 35, 30. 25, 20, and they are very useful to remove a fiber post, or also to clean dentin in the, for example, in the second molars or maxillary molars, because we have a good access and a good visibility when we use these ones. So, for example, here we had two long fiber posts in the canal, and we put it out by consulting with this with use of the I'm sorry, because the videos are very heavy, so we can see the fiber post in the middle of the canal with microscope. We can use these cutters for the consumption of the fiber posts. And then we find gutta perca and canal after the consumption of the fiber post. And we can perform the removal of gutta perca and we complete the shaping. So we can perform the irrigation of the canal. This is the view of canal after shaping and removal of fiber post. And then we can make obturation with the bioceramic cement. I use it as a lateral cold technique. So I put inside the cone, so we can see, we use the bioceramic sealer, not a sealer, but like a filler of the canal space. And this is the final radiograph. Okay. So next step is the removal of root filling material. How can we perform this removal? We can find gutta percha cones, cement like N2, endometasone, iodoform past, or carrier-based obturators like Thermafil. We can perform the removal by protaper retreatment, by other instrument like this of Comet, but I prefer to use to perform the removal of root filling material by using reciprocating files like reciproc blue or Excalibur of Zach. This is one of my favorite. It has a 5% taper, and I use it in a solvent bath with a push and pull technique of 1 millimeter every shipping time. These are the solvent I use is GPR or orange solvent. The first is a mixture of limonene and dichloropropane. The second is made by essential oil. But it's important to say that the using of solvent increases the residues of gutta perca and cements, and it worsening the final cleaning level of our work. So if is it possible, I don't use solvent any time. If there is only cement like this one, N2 was a cement used in Italy in last 30 years, it's very simple to perform our retreatment. We can use a single instrument to perform the retreatment, just to remove the cement. But in these cases, there is an high risk of post-operative flare-up. So patients can have an abscess because these canals are very full of bacteria, has a lot of bacteria inside. This is a case of the only case I have to use. I had to use the endosolver because this filling material was red Russian. It was a case performed in Ukraine, if I don't I remember, and in that country they used cement, resinous cement named Red Russian, and I need an ultrasonic device like this 8025 and this solvent for resinous cement because it was very hard to remove. Thermofil removal is very simple. We can use an H file to remove the carrier. Okay, and after the remove of the carrier, it's very simple to shape the canal and to remove the residual gutta percha. It's simple to retreat thermophil or other carrier-based obturation. Okay. How can we, the real challenge starts now. How can we obtain the patency of the apex? We can find three kinds of obstacles. It's mandatory to overcome these ones and to shape and disinflect in a complete way the canal until the apex to increase the success rate. Also, almost always when we see incomplete root canal fillings on X-rays, we find collagen plaques downstream the old filling materials. There are caps of collagen made by manual instruments in the previous root canal therapy. We can find also ledges, or we can find the broken instruments. The collagen caps have a rubbery consistence when cut by the files. They must be removed manually, only manually, with dedicated files for the patency, the C plus files, or these are micro mega K files. They allow us to obtain the catheterization of the canals to the apex, and we also it's very important to use glide, the collating glide, to keep collagen in suspension when we mobilized it. Okay. Here there is a case. We had a lot of collagen caps in the canals. And here is important our manual skill and patience is very important because the progress of catheterization is very millimetric. And a lot of time, the results on our fingers is this, a callus, because we have to work a lot with manual files to obtain the patency of this space obtured by collagen caps. This is another case. The canals are full of collagen caps. And we obtain the catheterization and we reach the apex by the use of these micro mega files, micro mega K files, because they have a cutting point and we can obtain the catheterization. Another case, and this is the healing. So a canal was unshaped to the apex, and they are filled by collagen caps. So we reach the apex and we obtain the healing of the case. Another important intracanal obstacle to overcome is a ledge, for example. It was created in the past root canal therapy by forcing manual steel files of big dimension in the canal. We have to overcome it to reach the apical third, to shape and irrigate it, to perform the healing of the case. So how can we overcome a ledge? They had an hard consistency to the cutting action of the files. They must be removed manually by pre-curving the manual instruments like a file 8, 10, 15, 20, 25. So they can be shaped also, pre-curving also the shaping instruments like these martensitic shaping instruments. And we can use the endo bender to pre-curve these our instruments, our files, manual and also the shaping files. The last obstacle is the broken instrument. We have an early radiographic and clinical diagnosis because we see the broken instrument in the radiographic. They have an hard consistency to the cutting action of the files. They can be removed only if we have a magnifying instruments, so only if they are visible. It's important to have, for example, loops with high magnificency or a microscope. It's the better way to remove a broken instrument. The risk of using ultrasonic on instrument that have been fractured is to break them further because they are oxides in the canal. We can also perform the bypass with the K files and manual night-eye instrument, so we can bypass the broken instrument if it's possible. For example, this is a case of broken instruments in the mesiobuccal canal. I removed it, and the MB1 and the MB2 was two different canals, so it was mandatory to remove the broken instrument. This is the follow-up at 1 year. 2 years, sorry. This is a lentulus removed from the canal to perform the retreatment. This is another file, easy to remove because it's very coronal. This is another lentulus, also easy to remove. But the risk here is that with an ultrasonic source, we can fracture it in a lot of parts. So we have to be very gentle. This is a broken instrument bypassed, another broken instrument bypassed. Okay, it was broken in the confluence of the canals, so we can overcome the broken instrument from the other canal, and it's not a problem because we reached the apex here, and the broken instrument was engulfed in the obturation material. Another case of broken instrument, it is visible also in the 3D radiograph. Two different canals. We have to bypass the instrument to reach the apex. This is another broken instrument, and we bypassed it because it's very difficult to remove this instrument so deep in the canal. We risk to be less conservative to remove that, to see and to remove that instrument. So the correct choice, according to me, is to bypass. This is an instrument fractured in the apex. We bypassed it, and here you can see the some obturation material that reached the apex. So we performed the bypass of the instruments. At follow-up of 1 year, the distal root is healed, but the mesial buccal root was not healed because of resorption of the apex. So we said that resorption of the apex had 40% less of healing ability. So we performed surgery in this case on the mesiobuccal root. So now we have discussed about the way to reach and shape the apical third, but after the use of night eye instruments, there are two another fundamental phase: the removal of residual gutta percha on the canal walls and irrigation phase. We have some wonderful devices like this one. This is the FKG XP Endo Shaper that has a whipping effect on the canal walls, creating the detachment of gutta percha residues. This action is important because the residual gutta percha can be a receptacle of bacteria. So after shaping with our night eye instrument, I use this one just to remove the residual gutta percha from the canal walls. Like in this case, this is a maxillary incisor. I perform the shaping. After the shaping, I use this one, 1 millimeter less to the working length, and show it with this whipping effect. It catch the residual of gutta percha or other cement in the canal and put it out from the canal. Okay. It's very useful to put out cement and other gutta percha residual from the canal. After the shaping to the apex. So I irrigate and I use another time the same instrument also to agitate the irrigant and to put out other cement other cement residuals. And it's important to clean deep as a deep cleaning of this canal because I have to fill it by MTA because it has a large apex. So this is the activation of irrigants by ultrasonic device after we removed all the gutta percha residual from the canal wall. And then this is a setting of MTA with the paper cone. And it's important to set it in cleaned canal, deeply cleaned canal. So we compact with the paper cone the MTA, and this is our final result. So canal wall are very clean in the irrigation phase, and the apex is filled by MTA. Last phase is one of the most important to increase the success of rate of our retreatment, and is the disinfection. And so the question is why we irrigate? Because there is a lot of areas of root canal that we don't touch with our 90 instruments. So these areas, the green areas, have to be solved by our irrigants. We know that irrigants are against biofilm, quindi streptococci, enterococci, lactobacilli, Yeats, gram-negative. Irrigants are direct against the smear layer to remove the biofilm and the smear layer. So we use ADTA and NaOCl. I use Niclor by percentage of 6% and the ADTA in percentage of 17% to remove both organic and bacterial residual and the smear layer from the canal walls. And I want to see these results. So cleaned to wool dentines. So a lot of studies shows that in small and circular canals, there is a percentage between 10 and 50% of total canal area unprepared after shaping. So we have to dissolve the content of this area only by using irrigants. There is a lot of amount of area untouched by root canal instruments. And if we perform a journey in the canal, we can see in red the area touched by nighttime instruments, but in green areas untouched by the instrument. So we have to irrigate and clean that area only by sodium hypochlorite. In some cases, it's very, very easy to vehiculate the irrigant to the apical third, like in this case, for example. But the activation of the irrigants is very important because allows the irrigant to reach also lateral point of exitus, so the lateral canals, then filled by our obturation technique. And this is a simple case because it's on just a simple canal, but it has a lot of point of exitus that created the lateral aspect of radiographical bone radiolucency. Both Sukis made these studies about fluid dynamics and about use of different kind of needle to vehiculate the sodium hypochlorite in the correct way to the apex. If we use some needle without side vented exit of the irrigants, we have the risk to vehiculate the irrigant over the apex and to have an hypochlorite accident. If we use a side vented needle, we vehiculate in a safe way the irrigant, but it is possible to vehiculate this needle inserted 1 millimeter from the working length just in right canals. In the curved canals, it's very difficult to insert these needles. So we have to enlarge our canals to insert this needle in the deep in the apical third. I use these ones. The endotop is 0.3 millimeters of diameter. And my irrigation is like this. In strict canal, it's very easy to vehiculate this needle to the apex. If we press, it reaches the apex. Okay, so we can vehiculate the irrigants correctly in the apical third. Like in this case, it's very simple sorry, the very heavy video. It's very simple to irrigate with this needle because the canal is simple, it's strict. And we can also use the activation of irrigant by ultrasonic device. But if we have this anatomy, this is a shaped canal, okay, and we can try to insert the needle, it don't reach the apex. It stops to the middle third of the canal. So what is the solution in these cases, in curved canals? The solution is the E-reflex. Is this beautiful device? It's a polymeric needle, very flexible, and it's very important to use it in curved canals to reach the apex with the irrigant. It has this flexibility and a double side vented exit. Side vented and double 2-point of exit. So it's mandatory, according to me, to use that needle in canals like this, curved canals, to allow the sodium hypochlorite to reach the apex. And this is the same tooth, and this is the E-reflex. It reaches the apex in a simple way, the same canal. It's very important to use this one in these cases. So, for example, in this root canal retreatment, we have the mesial root with this curvature, and it's very important to use the reflex to vehiculate in a correct way the sodium hypochlorite to the apical third, and it's very important also to clean in a deep way the endodontic space and to obturate with filling materials the entire endodontic space, and in 3, 4, 5 months we have an initial healing of the bone, and we saved the teeth from this bad condition of the bone, in the suffering bone, to this condition of healing bone. For me, it's impossible to not to use that device in curved canals. The time of irrigation, this is my time of irrigation time after shaping. In mono-rooted canals, 10 minutes. We can do 5 times the activation of sodium hypochlorite. The B-rooted canal, 12 minutes, and the multi-rooted canal, 15 minutes. Okay, and we always made an activation of the irrigants in some ways. What are the ways of activation of irrigants? This is one of the most important topic in irrigation, because by the activation of irrigants, we can increase the removal of organic tissue, the removal of bacteria, and the mobilization of the dental debris. And the literature describes the positive effect of activation and agitation of the irrigants. What ways do we have to activate make activation of irrigants? Manual technique, sonic technique, or ultrasonic technique? The sonic technique can be made by some devices like the endo activator. that is capable of transmitting a frequency between 1000 and 6000 hertz to the tip. I don't use this one, but I use another kind of sonic activation that is the Heddy, made by VDW. This is an enhanced sonic activation. This is my video of the activation by Heddy, because the oscillation frequency is above 6000 hertz. We need the insert to the Soniflex handpiece, but it's very beautiful because it's very functional to the activation. And this is the last way to activate make the activation. The ultrasonic device, I also use this one. The frequency transmitted to the point is 4000 hertz, so it's very strong. We put the irrigants to the apex, and then we can do the activation of these ones. I have already finished my presentation. So this is one of the way to obtain a deep cleaning of the endodontic space. And this is the result. The feeling of lateral point of exitus. It's very important in endodontics. Like this apex or this one. We have a lot of point of exitus, the apical delta, apical bifurcation. This is like a diapason, and we can perform the deep cleaning of this apex only by activating our irrigants. And it's very important also for the isthmus between the canals. All the bacteria and organic tissue in this isthmus, we can solve it only by using irrigants and the activation of that ones. This is, for example, an apical delta filled by materials only after the activation of the irrigants. Or this apex, for example. Two ways, so we can shape only one direction of this apex. The other one is the bacteria are solved only by activating the irrigants. For example, this apex of the first lower mandibular tooth. And what is another system, innovative system to perform the cleaning of the apex? This is the evolution of the endovac system. The endovac is a system of negative pressure system that bring the irrigants to the apex by creating a negative pressures. And this is the IVAC, the newest system that the principle is the same, so to veiculate the irrigants to the apex by a negative pressure, but the microcannula is linked to the ultrasonic source, so it can bring by negative pressure by aspirating the irrigants to the apex, and in the same time the ultrasonic device activate it in the canal. We have only to put the irrigant in the pulp chamber, and the macrocannula bring it to the apex by a negative pressure system. So this is one video. Sorry, it's very big. Okay. We only put the irrigant in the pulp chamber, and with the cannula, okay, you can see the aspirating power of this system. It bring to the apex the irrigant. We can bring it in a safe way, because we can put the cannula, the green cannula, to the entire working length, so to the apex, and the cannula bring the irrigant to the apex, aspirating it by the pulp chamber. This is the first case of retreatment in which I use this system, and this is the results. The very good results on the apex, because 3 points of exit cleaned by this system. These are some cases, for example, of missed MB2. It's very important to find, to clean, and to shape and to clean the MB2, because, for example, in this case, the reason of the failure was the missed MB2. And this is the healing in the CBCT views at full hop. Or another important canal not to be missed is the middle mesial canal in the lower molars. Like in this case, we had an independent middle mesial canal with the it has an independent point of exit. So we have 3 canals in the mesial root with 3 points of exit. Or for example, here we have missed canal, C-shape anatomy, poor shaped canal. So there is a world in this in the apical area, and the first treatment was not good because it was not filled all these apical delta, apical point of exit is. This is not the subject of my report today, but surely bioceramic cements give us a greater chance of healing in cases of retreatment in which the canals are not perfectly dryable due to a pre-existing problem, for example, of an endoperio nature. So this case of lower molar, this is our filling with the bioceramic cement. This is a big lesion with the fistula and the endoperio lesion, and the canal was not I cannot dry in a perfect way the canal, so I used the bioceramic, and this is the 7-month follow-up, and the fistula is compared, and in a very in less time that in the past, we can obtain the healing of the bone, and we recover all that bone in the distal part of the tooth. So we save the tooth and also the bridge. I conclude my presentation with the famous phrase of Edison that underlines how much patience and perseverance one must have in endodontics, and especially when it comes to retreatments. Thank you.
Thanks for your great presentation. We enjoyed a lot about the details and all the amazing cases that
Thank
you
you.
have talked about. It was very impressive. You're very talented, and I think the documentation of your cases is very impressive, and all the participants need to learn how to have documentation like you for their cases. This is very important
Thank you.
nowadays by having dental operating microscope and such devices. Okay, if you
Thank you.
can stop your screen, we want to have a brief discussion about the cases and about the concepts that you have talked about. I just want to start with Dr. Ahmad to start to have any question. If you have any question or if you have any comment about what we have seen, please feel free.
Okay, first of all, thank you so much, Andrea, for this
Thank you.
nice presentation, nice cases. You have covered a lot of topics, very interesting topics. It was very informative.
Thank you.
Uh,
It's very difficult in just 1 hour to cover a lot
yeah,
of
yeah, yeah.
concepts and to show to you some techniques, some skills to perform that results.
I see. I can see. Yeah. You've mentioned something very important about fiber post removal, which
Yes.
is, in my opinion, it's one of the most difficult topics in endodontics.
Yes,
Uh,
also according to me.
yeah. What protocols do you usually use to remove the fiber post?
Okay. In the past, I used the ultrasonic devices, but I don't use now that devices because the ultrasonic come si dice brucia? Produced a lot of I don't say in Italian.
Debris or
Breeze, yes, the breeze, and made it makes the fiber post dark, very dark, because it
Burn it.
transmit the fire, like the head to the fiber post. So now my protocol is based on using of the drills that I showed to you, the Comet Endo Tracer, that are long drills, because they allows me to see where I am working by millimeters. I put the 25 and the 20, the red drill and the green the yellow drill. Okay, I put it 1 millimeter, 1 millimeter the drill, and I use also the hair to remove the debris from from the fiber post while I am consuming it. But I consumed it by 1 millimeter. I stop, I use the hair, I consume another millimeter, I stop, I use the hair, I consume another millimeter, and always by loops with the light, or if I had microscope, it's very easier to do this phase. When I'm not sure that I am going to in the right direction, I stop and I put a radiograph every time. By if I use loops and light, I can see the difference, because the between the white of the fiber post and the yellow of the dentin. So it's simple. It's more simple. But if I had a very long fiber post, it's very difficult to consume the phase of consuming the fiber post. So I need a lot of time, and I penetrate 1 millimeter by time, every time 1 millimeter. And with the hair, I put out the debris to see the difference of the color between the fiber post and the dentin.
Yeah, and also I think there is another useful technique using the guided endodontics. We can use as the same one that we use for calcified canals. We can use it to drill the fiber post safely.
Yes,
Yeah, it takes some planning, some efforts and planning, but I used it and I found it very useful to remove
the fiber
the
post.
yes. I've never tried the drills that you've mentioned. I usually use ultrasonic tips or the guided endo. The guided only in cases whenever the fiber post is too long Okay, well, I cannot reach and see what's inside the canal, as you said. The canal will become very dark. What I follow is I follow the crystals of the fiber.
Yes.
Once I see crystals, I keep going, and as you mentioned, I keep taking multiple X-rays with a DG16 or any manual file to track the original canal.
Yes, but it's the safe way to remove the fiber post. I use the guided technique for calcified canals, but it's a very good idea to use it also to remove fiber posts, especially if they are very long.
Yeah,
Thank you.
exactly. Thank you.
And my question is, what is your preferences for the situation of the canal? If the canal is wet or if it is dry, which one is better for removing the fiber pores? Some claims that when the canal is filled with, for example, saline, it is better to see the difference between the fiber pores and the dentin. But some others claim that when the canal is completely dry, it is better to
Yes.
distinguish between the fibers of the fiber post and the dentin. And
I
what is
am
your
uh,
idea?
I am in the of the idea that if the canal is very dried, it's more simple to see the difference between the color of the fiber post and the color of the dentin. So, for example, I say to my assistants to put the hair in the continuously hair in the canal while I am doing the consumpting of the fiber post to have dry canal. So I prefer to dry the canal to see the difference between the colors of fiber post and dentin.
Thank you. Very good for having more time about the question and about the discussion. I want to ask you all respectfully to keep the answer to as short as possible, if it is possible for you.
No problem.
Okay, dear Ahmed, if there is there any comment or is there any question, please go on.
About the bioceramic sealers, what's your protocol to remove bioceramic sealers?
This is a very interesting question because I use bioceramic sealers, but I don't use bioceramic sealers in all cases because it's very difficult to remove it. I made some retreatments on bioceramic sealers, and if the colleague used a cone, a gutta percha cone, in the until 1 millimeter to the apex, is it possible to retreat? Because we can solve and remove the gutta percha cone by rotary or reciprocating instruments. The last part of the canal filled by a bioceramic sealer is very hard to remove, and I use a lot of ADTA and just manual files like that C plus or micromega K files that I showed to you to remove the collagen caps. They are useful also to perform the characterization of the canal if we find a bioceramic cement. But also literature is underlines that only the 30% of that canals can be retreated because bioceramic sealer is very good setted and is very good filled in the canal, it becomes like stone. It's very hard to work and to remove. So my hope is that bioceramic sealer is all is filling up the last 1 millimeter of the canal, so the rest is gutta percha. In some cases, it's impossible to retreat. Some clinicians used also formic acid to try to solve the bioceramic sealer, but it's not possible in some cases.
Thank you so much. Thank you so much.
Very good. Thank you. Very informative discussion. Thanks for your
It's a
insightful
pleasure
question,
for me.
Dr. Ahmed. Thank you. And thanks for
Thank you.
your answers. We learned a lot. Okay, Dr. Parisa, if you can hear me, if you have any
Yes.
question and comments, please go on. Thank you.
Thanks, dear Dr. Andre. You explained all your cases really beautifully. I had a question.
Yes, sir.
In one of your cases, I saw that you used microsurgery, I think, and I
Yes.
wanted to know that in that special case, did you retreat the case and then used surgery, or just you only I mean you straightly forward went to surgery? Because I didn't understand, in my daily practice I prefer when I have failures or I need to have a surgery, I first retreat my case if it's possible, and I have a straightforward access. I wanted to know, in that special case, did you use retreatment or no?
Perfect.
And
It's a
in
very
that,
Yes, it's a very
and
beautiful question. Because in my protocol is to perform for first the retreatment, to wait 9 months and to observe the possible healing of the bone, because a lot of times it's not mandatory, it's not necessary to perform the endodontic surgery, because the retreatment success rate, if we shape, if we irrigate and if we fill in a right way the canal, is very high. It's 80%. So the first way is to retreat the canal. In that case, the patient has a bridge, and she doesn't want to make another time the bridge. So she doesn't want to have the access to the bridge. So I perform directly the endodontic microsurgery. Okay, if the patient was wanted to remake the bridge, I suggested to her to remake the bridge, but she didn't want. So I performed the microsurgery not to touch the bridge no, not to touch the bridge, and not to damage the bridge. So I performed the surgery. But in my opinion, if the excellent resolution of that case was to remake the bridge, and I had to perform the retreatment before doing microsurgery, maybe, and maybe it was not necessary to perform surgery in that case. But the patients, I decided by the patients.
Okay, I agree with you, because in some cases, really, we have a beautiful crown. Everything is, we have a great coronal seal, and I agree. In these cases, maybe the economy, the money, some things like these is a big matter for the patient. And if really we have a good coronal seal, I agree with you. And I had another question. We have a concept called selective retreatment. And in some cases, that we see that, like in a mandibular molar, maybe the distal canal doesn't have any lesion and everything is perfect in the radiographic, but the mesial canal is not good, or maybe it has an infection. And in that cases, some of the endodontists prefer to use selective retreatment. I want to know, do you agree with this concept, or no, you always retreat all of the canals? Because some have this concept that when we start the retreatment, it's better, and it's they prefer to do all the retreatment from 0 to 100. I mean, they retreat all of the canals, and they say maybe we have microorganisms in even the canals that we don't see radiographically the lesion. I want to know, do you agree with selective retreatment or not?
Thanks, Parisa. It's another beautiful question because it's another important topic. At first, if I see in 2 dimension a correct root canal treatment in a canal, I make a sectional CBCT. So I go on 3D views by sectional CBCT of that tooth, and I observe if there is a lesion in 3D view, because in 2 dimension it's possible also not to see a lesion that there is on the 3D views. So when I perform the CBCT, I can also decide to retreat just the medial canals and not the distal one, because I'm sure only by 3D radiograph that there is no lesion. But if we want to be perfect and we want to be not to be criticized by other clinicians, if we, especially if we have to do a crown or a bridge on that teeth, we have to retreat all the endodontic space. Also, if there are canals without visible lesion, because the lesion is not visible today, but among 5 or 6 or 10 years, it can be appear, it can be manifest a lesion. Okay, and if we had a crown or a bridge on that tooth, we are responsible also of the endodontic safe of the endodontic health of that tooth in the life. Okay, so if I have to make a prosthetic crown or a prosthetic bridge on some teeth, I prefer to retreat all the canals. If I have to make an indirect restoration or like only inlay in a composite, I can perform sectorial retreatment, because I have the chance to not to enter another time in a simple way on the tooth.
Okay, thanks.
Thanks to you.
Yes, you explained it very good. I have another question. In your explanation, you told us that you use K files, micro mega.
Yes.
And in some of my daily routine endodontic retreatment that I do in my private clinic, I use H files for retreatment. I wanted to know that why K files and not H files, or maybe you use both, because when you were discussing about retreatment, you I think focus on CAR files. I want to know that do you use H files also? Because you told us about rotary retreatment files, but you didn't tell us about them. Do you think they are safe or not? You don't use them in your daily practice for retreatment?
Perfect. It's another interesting question because in the last years I used also the H files because they have cutting point. No, so they have a cutting force. But there is a problem which with H file. They are not safe because they are very fragile. I broken some of it in my while I was trying to perform the catheterization of the canal. These especially these K files or the C plus or the micromega K file are more safe than H file. They have a cutting point, but they are strong. They are less fragile than H file. So for me. The safety is very important because I have to I have not to have the risk to break an instrument in the canal while I am trying to reach the apex and to remove the collagen caps. So I prefer this K file of Micromega or the C plus to the H file because they are more safe and there is less risk to break that instruments. But it's very important to use them in a delicate way, very gentle way, because also when we remove collagen caps, we have to perform the removal only millimeter by millimeter. So we have to mobilize the collagen by this K file to irrigate to go another millimeter, and I use the 8 and 10. I use the alternance of 8C plus 10C plus, 8C plus, 10C plus, and I go by millimeter to reach the apex.
Okay, thanks.
Thanks to you.
Okay, it was you explained. Yes, yes. And dear Dr. Ahmad or Dr. Ali, what about you? What's your opinion? Can we have a short explanation that what do you do for retreatment? Do you use other files? Or you prefer like Dr. Andre to use safe files like K files?
Okay,
I want
Dr.
to know
Ahmad, please.
what's your protocol for retreatment?
Thank you, Dr. Faisal, for your interesting questions. I want to ask Dr. Ahmad to tell his opinion. Dr. Ahmad, please give us your opinion about the selective retreatment, the previous question of Dr. Faisal, because I think the selective retreatment is also an important issue and topic. Please go on.
It's important, of course. I regularly do selective retreatments, especially in cases where I don't see any lesions on the CBCT. And also, when I open the access cavity, I don't see any caries or any, because sometimes when we do like a selective retreatment, we see a recurrent caries. So if I see recurrent caries, I don't I don't do selective retreatment. Even if I don't see a lesion and the tooth is going to be crowned in the future, I uh, I uh, I only do a selective retreatment when I see only a lesion on the CBCT on a specific root and no a good coronal seal. Regarding the retreatment protocol, what I usually use, I don't use the gutta-percha solvents. I heat the coronal part of the gutta-percha with a heated plugger, and then I go with rotary files. And sometimes when I see attached remaining or residuals of gutta-percha, I use ultrasonic tips. I find ultrasonic tips are very useful to remove the remaining gutta-percha. And sometimes I use the endodontic plugger from Dentsply, the size 15, the 10 one. It has a good visibility. I can see and detach the get patch from the walls. Regarding H files, I don't use them unless I see like a single cone technique. And sometimes, as you know, there is some stubborn get aperture in the apical third that is loose. After loosening it, I insert the H file, but I don't use it in curved canals because it might cause stripping perforation, as you know.
Perfect.
Very good. Thank you for your explanation and your detailed discussions. Okay, I do usually selective retreatment, specifically when I have the CBCT, and I want to go one step before, because the ordering the CBCT, I think, is very important. We have to know where to order CBCT, and for the retreatment cases, we have guidelines, we have AAE and ESE joint position statement about that we can use CBCT if we want to have any retreatment cases. And I do usually order CBCT because I think that CBCT is going to give us details that we cannot see by a 2D radiograph. And it is very important to have a 3-dimension radiograph to see exact details. And also we have another article by, I think it was published by Rodrigo, and in that article it was shown that when you have CBCT, the treatment plan it may change about 50%, and the percentage I think is very high. So we have to consider CBCT specifically for the retreatment cases. And if the patient is aware of the advantages of CBCT, I think they may accept. And I always tell my patient having CBCT is a big help for me, and I can have a better uh, look at what's happening and what I'm going to face if I start my treatment. And if they accept my suggestion, I will order CBCT. And then if I see that I have roots and I have canals that are not disinfected, or if I have a stable periapical site and there is no lesion around any root, I will do selective retreatment. And this is my concept, and I always go for that because it is very cost effective and cost benefit for the patients. If you do selective retreatment, you can retain the crown part of the tooth as much as possible, and it is completely based on minimally invasive concept, and it is very cost effective and cost benefit for the patients, I think. And the other part, for removing the gutta percha, my preferred protocol is to use the files that are specifically designed to remove the gutta percha, which are retreatment files. And if I'm not able to completely remove the apical segment of the gutta percha, I will go for H files. I like H files instead of K files. This is my preference, and I'm easy with that because removing the gutta percha with H file is more easy because of its spread, because of its flutes, and because of its blades. It cuts more efficiently the gutta percha. But I use K files if I want to find any pass, if I think that there is a ledge, or if I want to negotiate the canal through the apical foramen. I will use K files at the end of my removal part of the treatment. And this is my preferences, and this is the technique that I use more, and yeah, I'm okay with that. Thank you.
Thank you.
Okay.
So,
Yeah, I have other questions about having access cavity through the crown, because Dr. Ahmad, you were not at Iran, and also Dr. Ando, we don't have the chance to have you in Iran, but we had a discussion panel in Iranian Association of Endodontists, and in that panel, I talked about a case that which I did a retreatment through the crown, but there was a debate and discussion about having access cavity through the crown. is it acceptable or not? Because many prosthodontists and restorative specialists say that preparing access cavity through the crown may damage the crown, and the crown is not acceptable anymore. If you say, okay, I'm completely try to be as minimally as possible, but they will say that the crown is not acceptable anymore, that and you have to change the crown. I want to know your concept about having access cavity through the crown.
Yes,
Dr. Andra, and I will go for others.
yes, it's another interesting question because I talk with the patient. If the, of course, if the coronal seal of the crown is perfect, if the crown it was made not a lot of time ago, I talk with the patient, and he is informed that there is a risk of microchipping, of a fracture of the crown, and is informed that the crown will be different from the initial state of the crown, because we have to do an access, so we have to interrupt the integrity of the crown. In my opinion, if there is a single crown, I prefer to make another time the crown, and to work without the crown, so to remake it. So I disassemble the crown, I remove the crown, I work in the tooth, and then I make another crown. If the crown is was made in the past, and we can put out in a simple way, we can remove the crown, work in the tooth, and then put another time the crown with definitely cement. But my first suggestion for the patient is to make another time the crown. The different solution is if there is a tooth of a long bridge. Okay, just a tooth of a long bridge with this problem, and the patient has to spend a lot of money to make another time the entire bridge. So for me, in this case, I can accept the idea that I can access to the crown with a micro access, but I am saving the entire bridge to the patient, that the patient that has spent a lot of money maybe to make that bridge not a lot of time ago. So I talk with him, and I suggest to him to spend less money, just to make the retreatment by the crown, by the bridge, with this micro access, and we can use also some materials to link the composite of the restoration with the ceramic of the bridge, like the silane, like some materials to restore that bridge or that crown in the less invasive way, and in the most mimetic way.
Very good. Thank you. Thank you. Very, very impressive, and thanks for your detailed answer. Okay, Dr. Ahmad, what is your idea and opinion about having access cavity through the crown?
I highly recommend it. Of course, when we are talking about access cavity through the crown, we are dealing with properly adapted margins. Okay. Of course, if it's not properly adapted, we'll remove it and we'll do the root canal treatment without it. But I am with access cavity through the crowns. And in fact, my main concern is not about the strength of the crown. My main concern is what's under or what's inside this crown. Because in some cases, especially if last week, for example, I was removing a fiber post through a crown, and when I removed the fiber post, the whole crown came out because of the clamp. So, and
Okay, yes.
yeah, the margins looked perfect, but when I removed it, there was no roots, like
That
no
was
crown.
a surprise inside the crown.
Exactly, exactly. So
Yeah.
once I removed the fiber post, it was there was no crown. It was just remaining roots. Although I wasn't expecting it because the crowns radiographically looked good, and clinically the margins are properly adapted. And the patient sometimes might think that you have destroyed the tooth when you remove the fiber post, but in fact, the only thing that was holding it was the fiber post.
Yeah, exactly. Having documentation in such situations is very important because you can show the patient this is the initial part of the treatment, and when I remove the fiber post, you can see that the crown had came out very easily. But if you don't have any recording during the procedure, the situation is going to be very hard for the patient, and it cannot be acceptable for that. At least you have talked before to him or her. Yeah.
Exactly. I don't see
Yes.
Thank
if I don't see a cavity or I don't suspect any cavity inside the crown. I usually go for access cavity through the crown. And I tell the patient it's not my responsibility what's inside the crown. I can tell what's outside, but I cannot see what's inside.
Yeah, exactly.
Then you
Thank you. Thank
believe
you.
in this concept that we have sometimes really a black box, maybe and we don't have really a view what's inside.
Um,
But I have a problem with this because sometimes when a patient wants to agree with retreatment, I always say the risks to my patient, but sometimes really, when I think about selective retreatment, I say, can I guarantee to my patient that the vibration of the bear doesn't break down the seal? It's kind of risky. When I want to retreat, I want to give a high percent treatment with a good prognosis to my patient. And when I want to start selective retreatment, I really believe in this concept. But when I want to start it for the patient, I always think, okay, I'm doing this canal. Let me to have a little more time and completely retreat it. But I believe in CBCT, of course. When we don't have a lesion, maybe it's kind of maybe not a good thing to do. But when I want to retreat one canal, I prefer to retreat all of the canals. But it's my concept. Maybe you don't agree with it, but I think it's maybe a good thing to give a high percentage treatment, because we all believe in microorganisms that we can't see. Maybe you said a case to us. You told a case, Dr. Andra. It was really extraordinary for me because I saw after what 45 years, a lot of years. um I don't know. One was for your mother. I think it was really extraordinary because the treatment was really horrible. And when I saw the root canal therapy, I was, wow, what is this? But because of the perfect coronal seal, really, it was
My
perfect.
mother.
And it was your mother. It's a disaster when our family has a problem and we are endodontists, a specialist, and we can fix the problem, but we didn't do it. But sometimes when we see everything is okay, when we see the treatment of the root canal, we say, wow, what is this? It's horrible. Let us retreat. But when the patient doesn't have any problem, and the amount of years that you told us, one of them, I think it was about 40 years in one of your cases, that you told after 40 years the patient had symptoms, I think. And the case of your mother was really extraordinary, that it told us the focus that really coronal seal can do amazing things, and the result can, I really think it's a game changer, coronal
Uh,
seal. These two cases were really for me amazing, and I really like when other endodontists share these cases, because in our country we have maybe a same concept, but when I see in other countries we are sharing same concepts or no, different concepts, and these kinds of knowledge when we share, it's really good. Thanks for your extraordinary cases that you shared with us.
I'd like to mention something
Yes,
regarding that interesting case, is that beside the proper coronal seal, sometimes improper root canal treatment might work as well, because of maybe the time that they initiated the treatment, the canals were not infected. Okay.
exactly.
Yes.
Yes,
On
exactly.
this
Yeah, they
was
were.
surely my mother case was made on vital pulp, and with cement, mummification cement like N2, and with immediately seal made by amalgam. The oxide of amalgam was an extraordinary way to seal, to have an immediately seal. And after 47 years, the tooth is asymptomatic, and there is no sense of sufferance of bone in CBCT.
Yeah.
Sometimes we can report these cases and say that we have new concepts in endodontic treatments, like maybe sometimes even failures are not really failures, we just see them in radiographic.
Exactly.
Yes.
Yeah, very good. Very interesting cases, Dr. Andra. And I think we have also evidences about the impact of coronal seal, and some articles mention that the coronal seal has twice impact of having apical seal. And the coronal seal is always very important because the coronal part of the tooth is related to the saliva, to all the microorganism in the mouth. But the apical part is only related to the actually periapical and periodontium. And always we know that the main source of the microorganism and bacteria are from the mouth and from the saliva. So it is reasonable to see that the coronal seal is very important, and we have to rely on the coronal seal. And as Dr. Paris has said, that if we have this, that is vital, and if the pre-treatment status of the tooth is, for example, irreversible pulpitis or reversible pulpitis, we still have the chance of having success rate in spite of having, for example, underfilled obturations. And it was a very important points and discussion that you have talked about. Thank you. Thank you for your great and amazing points that you have talked about. Okay, I think we are running out of time, and I want to tell you that the result of the Real Madrid and the Manchester City, Real Madrid is one goal ahead. But
Yeah.
yeah, I just want, because
Okay, thanks.
I know your mind is somehow there, and you want to see the other part of the match. I don't want to bother you anymore, because we have talked about many details, many important details, and I think this webinar and this session is going one of the best webinars of the
Really
ELS.
useful, and a
Yeah,
lot
very
of
useful
cases.
because the tips are very amazing, and we have talked about the most important parts of the retreatment challenges, specifically the deep cleaning challenges. Thank you, Dr. Andra, for accepting our invitation, and we will have more and more program with you. Specifically, we need and we want to see you eye to eye, and in the near future events. Also, Dr. Ahmed, we didn't have the chance to meet you in Iran and also Dubai
Thank you.
session, but we know that we will find the time, and
Your
we will
heart is
have.
with us always.
Yeah,
Sure.
yeah. We are all eager to meet you, and
Yes.
we will gather together as soon as possible with an amazing programs. And the main goal of ELS is to gather amazing and talented and esteemed endodontists like you here. And it is a great honor for me to be a member of this journey to the future. And we will learn together, and together we become bigger. Thank you, thank you.
Thank you.
Yes,
Thank
Thanks
you.
for taking your time and giving us your time. It was very impressive. Sorry, I have to finish this session. If you have any final comments, Dr. Andra, because the main presentation is belongs to you, and I want to go for the final words, and we will finish this session all together.
Thank you. I am very happy to make this presentation because I have to perform better in my English because I don't talk in English from a lot of time, and so I have to perform I have to return to my fluency of English of past years. And I am very happy to meet some motivated colleague like you. And the question you have made to me after the presentation showed that you have good interest in this topic, and it's a hot topic for me because it's very interesting to confront with to talk with other colleagues to learn different things and new things, and to improve our clinical aspects. Also, listening your point of view. I hope my content is good for you, and I try to to compact a lot of things in just an hour of presentation, because I have thousands of clinical cases and a lot of topics to explain, and I hope we will see face to face, because it will be a pleasure for me, and I am very happy to be a part of ALS.
Thank you, thank you, thank you very much. I'm sure that we will meet each other very soon. I want to say that don't underestimate your English fluency because it is very good. It is very, very good.
Exactly. I
And
wanted to tell that also. Yes.
yeah, don't
No, thank
underestimate
you.
it. Yeah, and all of us are not native speakers, and there is no expectation to speak English very fluently or very speed or very actually slang words. But we know that we can speak very well and we can communicate each other by different languages, and it is very impressive, and it is very important that we have the globalization actually pattern here, and all the endodontists all around the world from different languages can speak English and can connect each other very good. And I think this is enough, and this is very, very important and amazing. Okay, thank you all. Thank you, Dr. Ahmed. Thank Dr. Parisa. Thank Dr. Andra for coming here and for giving us your time. I know that it is going to be late in many countries, and I want you to ask to watch the Manchester City and Real Madrid match and then go to sleep.
Thank
Thank
you.
you.
Have a nice evening. Have a nice
Oh,
night.
thank
Have a
you.
nice day.
Yes.
Yeah.
Good
Bye,
night. Good night,
guys.
everyone.
Night.
Good night.